would you confirm that you can see my slides? I'm not sure if I'm sharing it.
Yes, we can see your slides and we can hear you very well. Thank you.
Perfect. Thank you so much. So we want to talk about understanding sexual and reproductive health in palliative care from a patient-centered approach. But before we begin, I have a couple of disclaimers that I would like to share. And number one, like you've heard, I am a GYN oncologist. Therefore, a lot of the examples and references that I may share might be mostly centered on the female reproductive tract and the women in general. And so it does not show any bias that I may have against men. So it's just because of my specialty. And secondly, I am not an expert of sexual and reproductive health. So I'm really looking forward to an engaging conversation from you. And hopefully you can share as much as possible in this meeting. And thirdly, I'm a visual learner. So I use a lot of cartoons to get my message across, because my thought is if I share all the studies and numbers and percentages, means and medians, when you have a patient in front of you, some of those things, if not all of them, appear. And so it's all about how much you actually understand, so that when you have a patient in front of you, you can actually help them, and that's what counts. Okay, so when we're talking about sexual and reproductive health, this is one of the most under-addressed aspects of holistic care. We know with the WHO, it set forth a definition of palliative care as a holistic sort of care. But when it comes to SRH, this has really not been addressed very well. And it's not just in Kenya, but in a lot of countries around the world. So when we're talking about sexual and reproductive health, it just means that we are considering and managing any issues involving the sexual, reproductive, and any intimacy-related concerns that a patient might face during their illness, because from the time of diagnosis to the time of treatment, up until after they've completed treatment, their experience will keep on changing. And so the whole aim for this is to preserve the patient's dignity, to enhance their quality of life, because really that's all we are about, and to address any physical, emotional, and any relationship challenges that they might have, which are associated with their illness and the treatment. And so when you're looking at the impact of chronic illness, we find that despite what is thought to be important in terms of the treatment, the diagnosis, sexuality still remains a fundamental aspect of life. And so for many of these people, many of us in general, sick or not, the physical intimacy and even the desire of sexual expression does not come to an end just because we're sick or just because we're undergoing some sort of treatment. And you see, when you have these advanced illnesses, cancer and other complications that might arise from that treatment, from hypertensive medication to even chemotherapy, they tend to cause a lot of disruptions in the sexual functioning. And it's on all levels. It's not just the physical aspect that's affected. It's also the psychological and social aspect that the woman or man goes through. And more so when you bring about now the element of terminal illness. Now, whenever you give that kind of a diagnosis to someone, it's not only is the diagnosis life-changing for them, but everything else will sort of come to a stop, and it will really affect how they feel about themselves, how they perceive their body, and even their own sense of self whenever they're in an intimate or any sexual relationship. And so for the terminally ill patients, it's really important to capitalize on their intimate and sexual moments, because they remain a vital aspect of their life. And it really helps them be able to still connect with their loved ones and be able to find sort of meaning in living, in death, and also in dying. And this is not just things we think about. There's studies that have actually shown how people are affected when it comes to sexual and reproductive health and just being in palliative care in general. And it's been shown by one of the studies by Anna et al. When you tried, there were 3 groups of individuals: those undergoing palliative care, those undergoing oncology care, and those just in general practice, and how their sexual, emotional, and well-being scores varied. And you find by a score, they use the derogatory satisfaction. When you come from, or rather, when you interview a patient who's sick for any general sort of illness, they still had scored high. The derogatory satisfaction score goes up to 10. So those in general practice still scored about 4, while those in palliative care were scoring as low as 1.6. And the same narrative continued in terms of the strengths of the sexual relationships. Those in palliative care scored the least amongst the oncology and general practice patients. As for general satisfaction and even the frequency of sexual relations, you'll find that especially patients in palliative care and even oncology, they would score less than once or 0 to 1 in terms of not actually having any sort of sexual relations with their partner, while those in general practice still could record at least once a week or even twice a month. And so there was a quote that I found from a patient called Gidland, who said that nowadays there are only a few moments when I do not think about death, when I'm not besieged by what is coming. When I make love is one of those moments. Then everything else ceases to exist. Then we disappear in a bundle of bodies. I found this quote really powerful because, and we'll talk about this when we talk about some barriers, it just goes on to show, apart from all the studies that have been done, the meaningful impact that sexual and reproductive health has on individuals. So sexuality in all events remains important in whatever phase the patient is in. And these terminal patients, we should not think that they have no desire for sexual function and intimacy. So we need to understand that any sort of intimate relationship can actually change over the course of their illness. And for some of the patients, it might actually help them to reinforce their connectivity with their partners. And as much as sometimes it's not just the physicality that happens, but any verbal, non-penetrative sort of intimacy needs to be explored upon. And so from what the little that I've said, I'm sure you understand now that this is a very important topic, and it's one that people seem to shy away from, and there's some embarrassment that comes out of it. And I know as we go on and continue talking about this, there's some people I might make uncomfortable, but I hope that that will be one of the ways that we can get out of our shells and be able to talk about these things. So when I'm talking about sexuality and sexual and reproductive health, it's important to understand some of the challenges that men and women face while they're in palliative care. And one of the challenges is in relation to their sexual dysfunction. And this can result from the disease itself or from the treatments, and it can cause some hormonal changes and physical impairments. And these are things that we'll often hear patients complaining about, or even when we ask them, they'll talk about it. We all understand what erectile dysfunction is, loss of libido for both men and women. Women specifically suffer from a lot of vaginal dryness, especially after chemotherapy or radiotherapy, and there can be pain or discomfort during intercourse. And we know, especially for patients who are undergoing some sorts of chemotherapy, they tend to have a lot of nerve damage because of the medication. And this can cause a lot of numbness or even pain around the genital area, making intercourse become such a painful and terrible thing for them. And as we continue to look at some of the SRH challenges, we cannot stress enough about the reproductive concerns. And we, in all aspects of our lives, we've met young children with cancer. We've had women, in my case, a woman in her 20s and she has ovarian cancer and we need to remove her ovaries, remove her uterus. And so fertility always comes as a concern. For men, if they have testicular cancer, they might have to even have their organs removed. And so they might suffer a lot of regret over this unfulfilled parenthood aspirations. And so it's important that we understand that these are some of the things that they may go through. And even apart from the infertility, the hormonal changes that they go through, especially women, for example, who've been radiated in the pelvis, the ovaries are completely damaged and they end up going into early menopause. And that has its own side effects and challenges. Apart from the reproductive concerns, there's also a major psychological and emotional impact that comes from this treatments and the disease. And one of them is body image disturbances and anxiety about intimacy. For example, patients, again, who are undergoing chemotherapy, radiotherapy, they'll tend to complain of fatigue. They're always tired. So you try and tell someone who's always tired to try and have sex with their partner. It's next to impossible. There's some cancers, for example, vulvar cancer. The kind of surgeries that we do for vulvar cancer are so disfiguring. So this causes a lot of body dysmorphism for this patient. So you might even treat their cancer, but they end up looking so disfigured that they go into depression and anxiety and have a lot of stress, which of course negatively impacts on their desires and function. And one thing that has come across in all the papers that I was going through is that for the healthcare providers, one of the uniform things that was being said is that if patients had any concerns about sexuality, they would initiate these conversations during their clinic visits. And yet when you question the patients, they're saying, you know what, I was waiting for my doctor to say, to ask me about these issues. But since my healthcare provider never approached the topic, I kept quiet about it. And there's a paper I would really love if a lot of you could read it, if not all. And it's by Emma, and it said, the title is To Live Until You Die could actually include being intimate and having sex. And this is a focus group on the nurses' experience of their work and sexuality in palliative care. I've shared the link to it at the bottom, and the slides will be available to anyone who wants them. But this article gives us an idea about what goes through in the minds of healthcare providers when they're dealing with these patients. That simple things that we don't think about sometimes that have an impact on the patient's life and care that is brought out quite graphically in this paper. One of them was a nurse talking about an ALS patient that she had. And this patient, ALS can be very debilitating. And so they suggested to this patient, you know what, it's a male patient, you need to have a urinary catheter. And the guy would refuse, and they wouldn't understand why. Because, I mean, if you are barely able to walk to the bathroom, so you're having accidents along the way, I mean, even just for us who are normal, how many times have you been maybe stuck in traffic jam and you're thinking, oh gosh, if I could have a catheter right now, it would really help, you see? But for this particular patient, he would not accept the catheter. And one of the counselors, one of the best people who actually talk to these patients, actually hear what they're saying, suggested, do you guys actually know the kind of relationship he has? I mean, that catheter, to you, it's a simple thing. I mean, why is it even a choice that you have to decide yes or no? Do I get a catheter or not? I mean, it should be obvious. You have trouble getting to the bathroom, you need a catheter, it will solve your problems. But for this patient, he knew it will affect his relationship with his partner. And so it became not something that he would want to face and he would refuse it. And so small things like this are the things that come out and make it really impossible for us to understand more about this topic. And so I want us to understand, why do we have issues with this topic? What barriers are we facing when it comes to sexual and reproductive health? I'm going to look at 3 perspectives, starting with the healthcare perspective for us as healthcare providers. And one thing, and I know early in my career, I would prioritize treatment of the disease over everything else. The psychological function, the emotional function didn't matter. It was all about, you have cancer, I will remove your reproductive tract organs, I will cure you of the cancer. And that was it. But when we are talking about SRH, we'll not only focus on the physical function, but we'll also ask them about their sexual dysfunction, loss of libido. Most of the times we'll just record, yes, patients having loss of libido. They're not having any ability to have intercourse with their partners, and they document it, but you do not follow through with treatment. And this has been, unfortunately, a major setback by healthcare providers. And for some of us, we're just not adequately trained. And we focus so much on the clinical training that we do not know even how to assess intimacy for patients. And so it becomes very difficult for us to understand that young people, even adolescents, elderly people with life-limiting conditions, that they would even be interested in having sex. I know there were times when we'd have tumor boards and someone would bring up that, oh, this patient is a 70-year-old woman and she was talking about whether she'll be able to have intercourse or not. And there's some colleagues of mine that are like, but she's 70, why would that even be something in their head? But we have to learn to individualize each patient and to know that just because of someone's age, someone's disability, we should not make assumptions about them. And whether they're male, female, it doesn't really matter. Whether it's someone you've told that, you know what, you have a terminal illness, it does not matter. We should avoid making assumptions on the patient and listen to them. And the other major barrier is our own personal issues. You find that because of our cultural or religious background, things like sex, we don't even talk about it. Some of us can't even say the word sex. It makes us uncomfortable. And so the best way to go about it is to avoid it, because we feel very vulnerable about talking about things like that. And we go into denial of this aspect that most people are involved in, but we don't talk about. And that really affects how we are able to manage our patients. And the other perspective is now from the patient's point of view, rather. And you'll find that, number one, you've given this patient the worst news that they could ever receive in their life. They have a terminal illness, they have cancer, or they have a chronic illness that they have to take medication for the rest of their life. So they might have a lot of shame and fear and even embarrassment when you're telling them they have this life-changing illness. And then they start telling you, so now, yes, I have cancer, but am I going to be able to have sex with my husband? They can feel embarrassed. And so they might want you as the healthcare provider to initiate the discussions. And sometimes they feel scared about what the provider might say. And there was a paper that was talking about some women, a focus group discussion with some women, and they said that they actually felt that their doctors would dismiss any concerns that they had about sexual health. And this I have actually witnessed in a group consult that I had with some colleagues. The woman actually asked about this. I mean, will she be able to have intercourse with her partner? And a colleague that I was with was like, Mom, why are you thinking about such things? You should prioritize your health in terms of getting the treatment sorted. I mean, the cancer sorted. And you could see the distraught that came across this woman's face. And I thought, we can do better. And especially for these women or men who meet us for the first time during the consultation, they can't really bring it up. And one other thing is that at the time, they've already received this diagnosis. For us, we know we deal with a lot of patients who are going through cancer, who are going through chronic illnesses. So we are used to this. But for patients, some of them, they've never even heard of cancer until their diagnosis. And so they don't even know the impact of the treatment that they will have. Some simple things like, for example, if you tell them you're going to have surgery, remove your uterus. Some women don't know whether if you remove the uterus, if they'll still get periods or not. And so these things that might be obvious to us as healthcare providers, it's not so obvious to the patients. And so we need to be able to explain these things to them and not take their ignorance as stupidity or look down upon them that, mommy, you should already know this. No, they don't. And they've not been to med school. They've not been to nursing school. There is no place that they would have had the opportunity to learn about some of these things. And I've given talks in some setups where we're just talking about regular people like working in the bank or in factories, and raising awareness of, say, cervical cancer. That's one of my primary interests in oncology. And one of the questions that keeps coming up, especially for men when I'm talking about cervical cancer, is that if I have sex with my wife, will I get it? And so there is always those kind of fears that patients and even their partners will have that we need to address, and we should not take them for granted. And the last perspective that I wanted to look at is the systems perspective. And I don't even want to touch this with a hot rod because we know right now our healthcare system is literally a house on fire. But we understand from all the places that we work, from the private to the public facilities, we have a lot of lack. From the lack of resources, lack of skilled personnel, we don't even have time to speak to patients about this. I'm busy explaining to them about chemotherapy and how they're supposed to come for their treatment. Who has the time to sit and talk about them, about their intimacy issues and their bedroom issues? And I have maybe 40 more patients outside in a queue waiting for me. I mean, those kind of things are also failures in our part as the system that we belong to. And so while it might all look like doom and gloom, there's still ways that we can remedy this. As I've been talking, I've been sharing some of it, but I would like to go through it categorically. And please, Gladys, let me know if I'm running over time. So, are you still there? I hope I'm not talking to myself.
We can hear you, Doc. We are hearing you, Doc. Just
I thought I'd fallen off the planet.
No, please. No, you are good.
All right, so thank you for that. So let's look at some ways we can help these patients. And one model that has always helped me in my care of patients is this biopsychosocial model. And I'm sure several of you are familiar with this. And it's one of the ways that when we're talking about holistic care for our patients, we have to understand the physicality of their situation, which we almost always see, the social aspect, from their cultural aspect, their religiosity, whatever family circumstance that they might go through, all merging with also the psychological factors, like how are they able to cope with their illness, how is their self-esteem. And once you understand that there's this framework that works together bidirectionally, that encompass how the patient is able to go through the illness, go through their treatment, and even survivorship, it helps us to understand how to help them. And this kind of health-centered model, it's one of the simplest complex things that we can ever come across, but it really helps us to sort of separate the patient into these different aspects and at the same time bring the patient together. And so when you're looking at this, it's not just about the patient. You need to remember that as much as we have this one individual's intrinsic health, it's a construct relative to also another person. When you're talking about sexual health, this person is not going to be having intercourse by themselves. There's a partner in the mix. There's someone who they get intimate with. And so we also have to assess what that partner is going through. And you see, while we're talking about this, for example, this lady who's gone through radiotherapy, she's having vaginal stenosis, she can't have intercourse. We also need to know how is this affecting the partner's sexual health and in relation to seeing or helping the patient cope. Because one thing I'll tell you, and this is an example of a patient that I had recently. She's actually a teacher in her early 40s, and she came to me because she said that she feels her vagina has become small. Not she feels, actually, the husband feels like her vagina has become too small and he cannot penetrate her. And I said, I'm going to make people uncomfortable, but this was an actual complaint from a patient. And on exam, I found that she had cervical cancer stage 3B, meaning that she had involvement of the cervix, the upper and lower vagina were involved in cancer. So there's a whole mass eating away at her. On further history, she did confess that she'd been having irregular bleeding, heavy bleeding, and a foul smelling discharge. But this never brought her to hospital. What brought her in was the fact that the husband could no longer penetrate her. So that's how important partner health is in terms of managing this patient. And so when we're looking at the partner, we also need to understand that sometimes they might also be going through burnout because they have to constantly be taking care of this person, and sometimes they might even neglect them. And then seeing their partner going down, this guy maybe who's married, this beautiful woman with wonderful long luscious hair, and then she starts chemotherapy, her hair's fallen out, her nails have turned black, she's lost so much weight, she looks like a ghost or a shell of what she was. That also will affect the partner's health. And if they're not able to see that woman the way they used to see her, again, they might even not be able to take care of her anymore. And that's why we've seen even women, there's a study we're doing called the Every Woman Study, where we're looking at ovarian cancer. And one of the reports that we had was women being removed from their health, from the husband's health insurance because they had cancer, because the partner could not look at them anymore, you know? And this, some of these partners would actually have a lot of fear when they're dealing with these patients. Remember, I said, we see a lot of these patients, we see a lot of this disease, but to them, it's a whole new thing. They don't understand this. And so a lot of fears that they might have, they might be like, there's a husband who asked me about a woman who'd just gone through endometrial cancer treatment and was in remission. But the husband was like fearing to get intimate with her. I was like, what if I hurt her? What if I cause her to get a complication and die? And this was really affecting him, and to the point that he could not interact with the partner. And so the mental health of the partners also bears a lot on our patient's health. And so to make our work easy as well, we need to also make the partners or the caregivers make sure that they're okay. And this, sometimes I realized, even when I'm doing my clinics, I'd have a one-on-one with the patient, have a conference with the family, with the patient, and the times I'll tell the patient, now you wait outside. Let me talk to the family or the partner, and I find out how they're doing. And there's a lot that they can tell you, and some of the things you can actually help them with. And so we've seen that the physical aspects of the cancer treatments can be quite heavy, and I'm not going to go through this again. And so one thing I will mention when we're talking about things like infertility, especially for those who are going to go through, say, pelvic surgeries or chemotherapy that's going to completely, can I say, neuter them, it's always good to talk about some of these options. Like if you're going to, there's some women and men who've actually been able to donate their ovary or have their sperm harvested, so that it can be preserved and they're able to have children later. For some women, we've give them some hormonal therapy to be able to protect their ovarian function. There are even some surgeries right now that we can do for women with colorectal cancer, where we transpose the uterus, put it in the upper abdomen, and then the woman goes through radiotherapy for the colorectal cancer, and then have the uterine transposed back to the pelvis. And assisted reproductive technologies, this is things that are available to our patients, and we need to familiarize ourselves with them so that we can be able to present them to our partners. Vaginal dryness is a complaint that a lot of women will have, be it from the treatment they've received, from the hormonal damage that they're going through because of whatever illness. You know, for women, even if they're not sterilized with, say, chemotherapy or radiotherapy, if they're going through chronic treatments like some hypertensive medication, they're going through menopause, they will have this major complaint, and it can be quite damaging to them because they might bleed a lot and cause a lot of pain. So we need to be aware of the lubricants, the moisturizers, even the hormonal treatments that are available for these women. And one thing that I noticed, or even a lot of studies have shown, is that especially for healthcare workers, they'll be afraid to give, say, hormonal therapy to women who've had, say, breast cancer, and then they're thinking, if I give a vaginal estrogen cream, it's going to bring the cancer back. And some of those fears are unfounded. And so it's necessary for you to get the right information so that you can advise and help your patient appropriately. And then there's some non-hormonal options, like for women who've gone through radiotherapy. As soon as they're done with the radiotherapy, you can provide them with some vaginal dilators. I know in my practice, we've even used candles as dilators, and the women are able to gain back their sexual function. It's hard and it's a long journey, and you have to explain this to the patient. It takes time, but at the very least, it will help them. Things like loss of libido and erectile dysfunctions, there are various, what do they call it? Pharmaceutical means that we can use. There are medications for women like flibanserin, the medication like sildenafil for men, that's very popular. And all of this, they can be used together with lifestyle changes to promote the libido and even erectile dysfunction. So when you're taking your history, you're following up a patient who has chronic hypertension and the medication is causing him to have erectile dysfunction, don't just write in your notes, patient has erectile dysfunction. Find a way to help him overcome that, if there is a way. And so when you're talking about psychosocial dimensions, I've mentioned this, there's a lot of emotional challenges from depression, anxiety. I had a 20-year-old girl who had breast cancer. And you see, she was an avid basketball player. And then suddenly, to put her through the surgery, then she had to go through chemotherapy. She couldn't play basketball. She couldn't hang out with her friends. She couldn't be intimate with her boyfriend. And it really causes a lot of depression. You start asking yourself, why me? Why do I have to go through this? And so when someone has to go through all this, there's that physical aspect that becomes very critical and can disrupt a lot of relationships, be it an adolescent, be it a young adult, all the way to the 78-year-old man or woman. And so we still need to address them. And so there's a lot of means that are available, and most of this we know them from counseling and therapy. I know the African culture, we have this thing, we are strong with mental health is a problem of, say, can I say, the Western world, and we do not do therapy. But we have to understand that mental health is a priority, and being in therapy is not a sign of weakness. So even our own personal biases should not be reflected on the patient, and we should avail them to psychologist or even a therapist to be able to help them cope better with whatever challenges they're going through. There are medications that these patients can receive, and I find that sometimes we just randomly prescribe some drugs. Please be aware of the kind of medication you're prescribing, as well as the side effect that they might have in conjunction with the treatment that they're receiving for whatever illness that they're facing, because it's not a one shoe fits all. Every patient has to be approached individually. And Right now, there's quite a bit of support groups that have propped up. I know in Mombasa here we have Kehpca, which has really brought together women with breast cancer, and it's involving also some ovarian cancer women. And these support groups, it helps these women to know, or even men, to know that they're not alone in this fight. They're not alone in this journey. Because remember, I was talking about the Every Woman study that we did in Kenya and around the world. And some women were saying they'd never heard of ovarian cancer, and they thought they were the only ones in all of Kenya who even had that ovarian cancer, not knowing how common it was. So these support groups really help to help these patients share their experiences and even receive emotional support from others who've been in the same situation. You can never put the family aside. You have to always involve them. Sometimes families can be quite problematic. And I know, like right now, I have a woman who has 11 children. So that means I have 11 opinions to deal with. But we have to listen to them, give them room to speak, to air their views. It does take time. And remember, one of the system failures that we had was lack of time. But you can never be given time. You have to make that time, speak with the family, have an open communication. It becomes hard sometimes when some families like, don't tell her, others are like, don't tell this person. You need to find a balance. Of course, I cannot stress more on holistic care. I think we've talked about this. I've mentioned this before. And one of the things that you also need to put in place is the religious aspect. Kenya is one of those very religious countries. And so you need to be able to understand the background of the patient and help them. If going to church and participating in prayer groups, if that's what helps them, channel that and include a pastor. I was really impressed with how MTRH has a very strong spiritual health, can I say, program or activity. And to be honest, for me, when it started, I thought it was a joke. But the more I understood how patients value their relationship with God, relationship with a superior being, it really showed me how they can be helped and they can actually impact their journey in terms of treatment. And one of the final things in this is what we're doing right now, education, not only to the patient, not only to the family, but we educate ourselves as well about the emotional impact of this illness and the strategies how we can manage. One other way to overcome these barriers in terms of approach to sexuality and sexual and reproductive health is communication. Everything has to be patient-centered. You need to be open, empathetic. And one of the authors I've quoted quite a bit here is Margaret Lang, and she's done a lot of work in terms of communication, palliative care. And I hope you can get to read some of her works. And she said, sexuality is an important survivorship issue, and it remains relevant even in the terminal setting. And she goes on to say, if we're not able to communicate in a non-judgmental approach, this topic will remain underaddressed, and it will continue influencing our assumptions, our hesitations, and our patients will suffer a lot of prejudice. They will never have an improvement in terms of their satisfaction. And so it's very important for us to normalize these discussions. And again, I cannot thank Kehpca enough for bringing this topic up, because you can see how important it is. Because for some of us, when we're talking, we're not very good at communicating, and we are all in different aspects. And like I said, one of the barriers is for us, we might feel culturally, we cannot talk about these things. But one of the ways that is recommended to go through this, and this is part of Margaret Lang's work, is when you're talking to the patient, you're seeing them in the clinic or wherever you're seeing them from, have this like a conversation, like you're going through, like you're curious about someone. Imagine you're meeting a friend and you want to find out what's been going on for the last maybe 3-4 days or weeks that you've not seen them. You always have that curiosity approach. So you ask them some open-ended questions that will allow the patient to express themselves. And this way you will build a rapport with the patient, you will actively connect with them, and that way they'll be able to express themselves without fear of judgment. And when they're talking, learn to listen to the details, learn to hear what the patient is not saying. For example, a woman would come and say, you know what, these days I'm sleeping in a separate bed from my husband, and that's how we're living our life. And they will not really tell you why that is happening, and they'll just mention it flippantly. And it could be because maybe the husband is scared, he might hurt her, or she's having, if it's cervical cancer, she's having such a foul smell that the husband can't stand to be near her. And so when we learn to use this kind of a systematic framework, we are able to pull the conversation out of the patient. Because one thing about patients, they'll be like, I do not want to speak about other things that's not directly related to my treatment and everything, because there's this African stoicism that comes that, oh, because we're African, we're supposed to be strong. We're not supposed to complain. If you're complaining, it means you're not grateful to God and whatever higher being. And unless you course the information out of these patients, some of them will never tell you what they're going through. So just simple questions, ask them how they are, and it might actually open a discussion, and the patients might be able to open up to you. So there are several models available online that you can use, especially I was still learning how to speak clearly. And when you use these tools, they sort of help to, can I say, what's it called? Categorize your mind in a way that you can actually talk to the patient and express yourself and find out what you need. One of the validated tools that I thought was really helpful and has been helping me is the PLICIT model. And I won't go into all the details. I know it looks like a very busy slide, but when you look using the PLICIT model, you first sort of give permission for the patient to share. I mean, what I was saying, open the conversation so that patient can feel comfortable to share. And if the patient has some limited information about like some side effects that they might be having, things like that, provide that education that they need. And you can also give them some specific suggestions about what they can do, because medicine is not just pharmacological. There are also some non-pharmacological strategies that we use. There are innovative ways that people have found along the way to help these patients. So give them some suggestions. And of course, if the patient requires any intensive therapy, always don't never be afraid to refer the patient. And there are times when I'll tell my patient, you know what, I really have no idea what to do here, but I know someone who knows what to do. And you involve them in the patient care. So that's where tumor boards and there's just some people even who it might be, for example, a radiation oncologist, but they're so good at speaking to patients that I will call them and they have a conversation. In fact, there's a gynecologist who I work with, and he is so good at speaking with patients, such that when I know I'm having a terrible time communicating with the patient, I will call him in, explain to him what I need, and I put the patient in front of him. And you need to just find this strengths of everyone. Have an interdisciplinary care group that can manage this patient, make it about that one patient. Yes, we have diseases. We have ovarian cancer, we manage it a certain type of way. But when it comes to the patient, you have to look at the patient individually and give him or her the particular sort of care and support that he or she needs. And as I'm winding up, there's also a lot of cultural and ethical considerations. We know there's some beliefs that we go through. We have 40 something tribes in Kenya, and we all have different beliefs. So there's some things that we think, or rather, that might bias asked to patients and some things that the patients might be biased against. And so you need to be able to learn what works for whom. And the best way to find out is to just ask. I mean, the patients will come, in African culture, talking about death and dying is pretty much taboo. But you have to ask them, are you okay about talking about death and dying? Are you okay about talking about the final directives and things like that? You need to bring up the conversation. You need to ask what is acceptable to them and work on that. So, and just because something is acceptable or unacceptable to you, don't reflect your own bias on the patient. Be aware, first of all, of your own biases so that they don't reflect on the patient. And of course, education. We need to structure how we teach this in our schools. I'm proud to say that Kenya is one of the countries that has a good palliative care system. And I'm talking about palliative and hospice care system and training in medical schools. And so the more we integrate such kind of educational activities or programs, guidelines, and include sexual and reproductive health topics, then we're able to start from a very young age in terms of healthcare providers. We teach them how to get comfortable with these discussions and be able to help the patients as they need to. And of course, we need our own research. Surely, we run clinics where we have hundreds of patients coming in. That's a lot of data. Just because it's been done in the Western world does not mean it necessarily can reflect on us. And one thing that you'll notice, because of differences in, say, the global north versus what we face, they can be different. And so it's good we have our own studies. So this, especially for students, you're coming in, you're like, oh, I'm going to do, say, obstetrics and gynecology. Take up a topic on, say, palliative care, on sexual reproductive health. Make a topic out of it, and we can really add on to the data that we have. And so essentially, I'm winding up, hoping you're still with me, but everything starts with us. And the positive impact of giving sexual and reproductive care in men and women going through palliative care would be able to outweigh any negative aspects, any embarrassments that we feel, and other things that can be associated with this. Because with the focus that we give to SRH, it can actually help these patients be able to improve the quality of life. Because that holistic approach that WHO is talking about when it comes to palliative care, this is a very integral part of it. And patients, regardless what you might think, they still value intimacy and expression of sexuality. So now, for those who had dozed off or on WhatsApp and Facebook and whatever, this is the message. Come back in and listen to this. The most important thing, the key takeaways from this, 30, 40 minutes that I've been talking, is number one, we need to understand sexuality. It's a critical component in the quality of life, and it can affect how the patient goes through their disease trajectory in terms of the physical and psychosocial well-being. And majority of the patients, in fact, in that study that I was talking about, 71% of the patients, they wanted their healthcare providers to initiate the conversation about their sexual health. And even though someone is having a metastatic disease, for example, it might still be a concern to them. Give them that opportunity to talk about it. And we are faced with a number of barriers, which we know, but I'm hoping that right now we can overlook all these barriers, overcome them, and be able to provide an opportunity to address these patients in a way they can feel unjudged and they can get the care that they actually need. And of course, we continue with the structured education and training programs so that we can equip ourselves with the skills and the awareness that we can actually address these patients' sexual and reproductive health effectively. I thank you very much for your attention, and thank you for having me.
Thank you very much, Dr. Mburu. It was a really rich presentation, as some of the charts on the chat box. It was really an eye opener. I personally have learned a lot. Just to highlight a few, most of the time we take care of patients and we don't know what they expect from us. They come expecting to be addressed these issues before they bring them on board. That was a very key, something which came out very clearly. We need to anticipate patients' needs. It is true patients want us to start the conversation. Even when some patients come to the hospital and they go home with the pain, and when they reach at the gate there, they ask, why haven't you been given the treatment? The doctor did not ask me whether I have pain. So even this one, we need to start the conversation. I like the way you brought in the barriers in subsections, the healthcare barriers, the patient barriers, the barriers of the institutions. And these are things to learn, and then we start filling the gaps, because there is a lot of gap. Patients are suffering, thinking that we are treating the disease, and yet we are leaving the person behind. So let's work with the patient as we continue treating the disease. Of very much interest, and the most pregnant point I had is assessing the patient's partner. We completely forget about the partner. We are chasing this Gladys, Joyce, Rebecca, but we forget Mr. Peter, who is seated outside there, or who is seated here with the patient. We don't know how he's coping with this disease. We don't know how he's coping with these sexual matters of the wife. And it is a big mountain to him, because even to her, because we are not talking about sexual issues of the women, even to her, if the husband is the one who is sick. So let us remember that, and we put it in red in our notes. Let us remember the partners. Mental health is very key in our setting. We forget the mind as we treat the other physical areas. I also heard about, we take detailed history. Sometimes when the patient comes and they have these sexual issues and they are taking medications, we don't relate. Is it because of the medicine? Is it because of the disease? Is it because of the psychological? We need to treat the patient in a holistic manner. We need to learn to hear what the patient is not saying. I like the way the message has come out very clearly. The patient will come and talk, but we don't pick what he's not saying. Non-verbals. The patient will keep on going round. And remember, we are dealing with cultural issues. Let us learn these things. And the model was very clear, biopsychosocial model. There is a implicit model for addressing sexual issues. Let us go back and revise these things. Make use of people's strength as to navigate through these issues. You might not be a very good communicator at a place of work. Why can't you refer the patient to somebody who can? And I like what Dr. Mburu said, I usually call so and so and so. That is a challenge to us. Let us embrace each one's strength. Education. I want to repeat again, thank you, Kehpca, for bringing this topic. And I want to tell you that we've been speaking to 242 people. Actually, now there are 248 people. So we have impacted. Dr. Mburu, thank you so much. You have impacted to so many people. Education, we cannot overemphasize. Let us remind ourselves what the research is saying, evidence-based about sexual issues. And we also encourage Kehpca also to take this up. I know they are planning something which is going to be a big program, which is going to change our practice so much. But it can, before we bring it out, we want to encourage you to bring more and more of these CMEs to us, so that we can remind ourselves how to handle the patients with sexual issues. So well done, Dr. Mburu. It was a well-researched and evidence-based presentation, well presented. The slides were wow. I was waiting for the next slide to see the cartoons and the pictures. They were very nice and the audio, the voice was very clear, entertaining. I was just feeling like going on listening and listening. So because I don't want to take much of our audience's time, let me see whether we have some questions to address. How do we approach sexual reproductive health concerns in patients with the limited capacity to consent? I hope that is clear. Do I ask two or let me ask several so that you can address. How do we approach sexual reproductive health concerns in patients with limited capacity to consent? How, okay, this one won't. What are the legal implications of fertility preservation in terminally ill patients? Could you please, slides again. It's a great presentation. Maybe you can address those two kindly.
So much, Gladys, and thank you for the kind words and for the amazing summary. So the question was, how do we approach SRH concerns in patients who have what?
How do we approach sexual reproductive health concerns in patients with the limited capacity to consent?
Oh, okay, got it. Limited capacity to consent. So first of all, we need to know something, that no is a full sentence on its own. And so when you have now patients who are, say, 18 years and above, and they have some sort of disability, or maybe their mental capacity is not entirely there, there always has to be some power of attorney, someone who's been given the ability to make decisions for the patient. And so when it comes to these patients, remember they're also the highest risk for sexual violence against them. And so we must always be able to identify who's the key caregiver and who has, what I say, power of attorney, and always be able to protect them. In some of our communities, we rely so much on the what are the community health promoters and with the nyumba kumis and things like that. And so we might always want to check on them, make sure that they're okay. But when protect them from especially incidents of rape. And unfortunately, I've had several women who unfortunately have been victims of the same. And it's a topic that also comes in with the next question about the legal implications of fertility preservation. As it stands, as long as someone is an adult, defined by the Kenyan law as 18 years and above, they will have to give consent whether they want to go through fertility preservation or not. So if it's the lady, is she accepting for her eggs to be harvested? If it's the man, is he willing to donate his sperm? And the point can be either for someone else to use them or for them themselves to use them when they are, if they're able to get better, or if not, then someone else uses them. So there's still a lot of legal quagmire that has not been quite sorted by the Kenyan law. And if there's someone who knows better, please let them speak up. But there has to be lawyers involved. There has to be a lot of documents that have been signed to indicate that the person is not being forced into it. For those who are less than 18, of course, the parent has, unfortunately, the legal right. But again, some lawyers have to be involved in all of that. And I really hope there's a lawyer or someone who deals with this who can answer better.
Thank you. Thank you very much, Dr. Somebody's hand is up. Maybe I can start with Mary Watata. Watata. Your hand has been up since we started. You can start with you. Are you muted? Emily, you can unmute Mary Watata. Then Wefwafwa can follow. If you are unmuted, you can speak. If Mary is not ready, kindly ask your questions or your input. Or is it by mistake? Lawi, Jiro? Emily, are they muted?
They can speak.
Thank you. Thank you. This is Wefwafwa.
Okay, thank you.
Do you hear me?
Yes, we can hear you, Wefwafwa. Go ahead.
Thank you so much. First, I want to really appreciate the topic and the presentation by Dr. Muru. Sexuality in palliative care is not just a topic to be shared lightly. It's deep. I'm in Bungoma County, where we have a lot of cultural diversity and beliefs and so many issues. So my input was that I have personally handled patients like one. We had a patient who developed severe breast, but she remained very strong that during her time with her first boyfriend, that the boyfriend like sucked her breasts. So she is strongly believing that culture, he was not supposed to have, the man should not have done that. So she has really fought the fight, not believing. She has stayed in denial that this is not cancer. My boyfriend sucked my breast for the first time, and I'm going down in pain. So when I have today seen this topic of sexuality and all this, it has taken me back to that pain of that young girl who we did a lot of psychological counseling, supporting her psychologically and helping her to fight through the process of cancer treatment, but she never accepted. That's one I want to appreciate. I have so many examples that I can give. So this topic of palliative sexuality in palliative care, it is to me, it has touched me, that I request that Kehpca you proceed on. I want to appreciate Emily and all the people in Kehpca that we keep on sensitizing and having these lessons to us as healthcare workers, especially in rural down areas like where I am in Bungoma, that people have some cultural diversity and beliefs about the onset of several cancers, which are not, may not believe that this medical, that they may think this cultural. To me, this topic is very vital to us. So please, I want to echo your support. I want to appreciate you that indeed it is we need it. Thank you so much. That's my
Thank you. Thank you, Wefwafwa. Thank you for your good comments and also for the sharing the experience. I want to give Mary Nyaga this opportunity to ask questions, and kindly, when you're asking your question, go straight to the point so that we can address so many of them on the chat. Mary Nyaga.
Thank you very much for this opportunity. Mine is actually not a question, but a concern to Kehpca. On matters fertility preservation, we see that the cost and accessibility is limited. In many places, fertility preservation is not covered by insurance, leaving patients and their families to bear the cost. Maybe Kehpca should consider this as SRS champions to lobby for share coverage on fertility preservation. Thank you very much, Dr. Nisa. I'm from Coast Hospice.
Wow, thank you so much, Mary. A challenge on us and on Kehpca And that is going to be addressed. Maybe Mr. David, when he's talking to us at the end, is going to address that. Maybe I can read a few comments on the chat, and most of them, they are just compliments, and we appreciate them. Very powerful presentation. Kudos, Doc. Wonderful presentation. Very, very key area in palliative care. Yes. You cannot address our patients' palliative care needs without addressing their sexual issues. Nice job, Doc. A nice, insightful talk. Nice presentation. Quite informative. A wonderful eye-opener. Great presentation. I've really learned a lot. I'm very happy to join this meeting. Have learned a lot. Thanks, Doc. And also for parents taking care of hospitalized cancer children. Sexual issues is a challenge, a big one. I've really learned. So I want now to give a chance to Lewis. If you are still, if your aunt is still happy, you want to say something as I go through the chats to see whether there is a question. Lewis, do you have a question? Is there another aunt I'm missing? Sophia, you can go ahead and ask your question. Sophia, who?
Thank you very much. My name is Sophie from Nakuru. With the current trends that are there, and we have many young people who are being diagnosed by CA, I have a question for Dr. Matters SRHR and sexuality. What is your thought about pleasure? Because we get like people are so exposed from the millennial bracket downwards, and with the, without mincing the word, things like dildos being sold in the streets. And here comes a couple, maybe the patient is a cervical CA, and then the husband wants to, maybe for pleasure's sake. Would it be harmful? Things like maybe it's a prostate CA, and then things like blowjobs. What would you recommend? Because maybe we are dealing with a young age group that could be diagnosed as patients. Thank you.
I absolutely love it. And yes, I should have spoken out about this. And I 100% recommend. Because remember one thing that I said that, especially when it comes to intimacy, sometimes it's not just penetrative. There are different ways that people can get pleasure. And honestly, it's one of the best ways to help these women and men sort of get out of their own heads, focus on something that is giving them pleasure. Remember, like the quote that I shared earlier from a patient who said that the one time that they can forget they're terminally ill is when they're making love. And so if they find a way to use a toy that gives them pleasure, there are several in the market. All I recommend is that don't share, keep them clean, and use them to your heart's desires. It will actually help with their treatment and overall health.
Thank you. Thank you, Dr. Mburu, and thank you for that question, Sophie. I go ahead and read more questions in the chat. Emily is asking, in Kenya, which facility offers fertility preservation? And then there is also someone else, Jacob, saying, great job indeed, Doc. Kindly remind the silent learners who qualify that we have the HPV vaccination as a prevention of cervical cancer. This population is here with us listening. Otherwise, thanks and God bless. Maybe you can handle those two.
Right now, there's a lot of facilities that cover artificial reproductive technologies, and part of it is fertility preservation. So many of them are private hospitals, And so you just have to find out which one works for you. There's none I will specifically recommend, but for everyone, I'd request that they do their due diligence, from online reviews to patient or consumer reports, and be able to make the best decision for them. But these services are available, very costly. And so I would like to echo the lady who said that we need to have this covered by the health insurance, because we are seeing so many young people who could benefit from this service. The question on HPV vaccination, it's, yes, different from what we're talking about today, but I will never shy away from talking about cervical cancer. Please, HPV vaccination has been proven to be effective and safe in young boys and girls aged 9 to 14 years, mostly because they have not gone through or have not been exposed to the virus through sexual intercourse. HPV, as we know, is a sexually transmitted infection, the commonest infection, and the best way to protect someone against them is by giving them the vaccine, so that to boost their immune system, so that when they get the virus, and you say I'm saying when, not even if, when they get the virus, they're able to fight it and keep it from persevering in the system, resulting in HPV, in cervical cancer. So please, it's free right now for any Kenyan girl between 9 and 14 years. Single dose has been shown to be effective. The national government is yet to recommend it as the standard, but if a girl has received one dose, they're covered. It's efficient, and it has been shown that it lasts, the protection lasts up to even 20 years. So please vaccinate any girl who comes to your clinic, or you meet them, or you talk to them in the villages. Let them come to hospital, let them get it free of charge. For the boys, those who can afford to pay, there's some health insurances that can pay for it. They can also get vaccinated.
Thank you. Thank you, Daktari. The last question, let me do the last question because we need to wind up. How accessible are sexual therapists for our patients in our settings? And then Gilbert is asking, I don't know whether he's asking or he is commenting or he's telling us his experience. What role does sexuality play in maintaining quality of life for patients in palliative care? It is not only palliative care, I think in human beings, we can talk about that. How can palliative care teams create a safe environment for patients to discuss their sexual health needs? Those are the last questions I'm taking because of time, because we need to hear from Kehpca, the CEO, and the others, Dr. Buru, the others are compliments. Please, I did not go through all of them, but there are so many. Feel appreciated. We really appreciate your work and your presentation. Just address those two, and then I welcome David to talk to us. Thank you.
I'm really humbled that my little knowledge in this field can impact on someone and they can actually do what is right for their patients. When it comes to the question on, I think, sexual therapists, it's something that I also struggle with because we have very few in Kenya. And unfortunately, even the ones who are there, because of this being a taboo topic, they can get a lot of restrictions and even hate from people. They keep their job quiet. And so it's our responsibility to be able to provide a safe space for sexual therapists to come and say, you know, I have this skill, let's use it. All right. So right now, I know there's a lot of patients who do not have access to a sexual therapist. The question on the role of sexuality, I think my entire talk has been on the quality of life or the impact that sexual and reproductive health has in the quality of life of patients. So I really can't go back. But the most important thing is that it helps them from their physical aspect, the psychological, and even their social aspect in terms of the relationship they have with their partners and how they even feel about themselves. It has a very big impact. And for about, I think it was creating a safe space. that one, it's not just about SRH. It's every time a patient comes to you, just that contact that they have with you from the first visit, it has to be a safe space. From your demeanor, being able to do it in a private room, being able to recognize that a particular patient would prefer to have a one-on-one with you compared to having the partner or the family included. There's some patients who would not want to have students around. And I know, especially in our public hospitals or the university hospitals, we tell them, no, this is a teaching hospital, so the students have to be there. And that is part of not creating a safe environment. So there are a lot of facets that we can do to provide that kind of safe environment for them to be able to speak about their sexual health needs. And we also need to bring it up so that they can be able to open up to us. Otherwise, thank you very much.
Thank you, Dr. Mpuru. Hey, now somebody has raised another hand because I don't know whether it is burning. Alex Omondi, if it is burning, I can give you a few seconds. Just pop up and say what you need to say to Dr. Mpuru.
Okay, thank you very much. Yeah, I'm Alex Mondi. I'm currently a student where I'm working on things to do with the cervical infection. So I came across a question from one of my colleagues, though he's not a medicine student, but she came to ask me a question. And says maybe he had a girlfriend who have a problem with the cervical things like infections. Then they came in together. They had intercourse. Then the problem is they failed to protect. So he came to me now. He thought maybe I might have an idea which I don't have. Then after some weeks, he thought he might be having the infection as a man. So I was wondering, does that cervical infection from a woman can be transmitted to a man? And if, how long does it take to show off, to come out? Because it has been around 2 months, but the man is still just okay. And if it is there, and how again can he prevent it? Yeah, that's my question. Thank you very much. I'm Gladys.
Thank you. Dr.
I think what you're talking about are vaginal infections, not cervical infections, because vaginal infections, they are different. They can have the regular non-sexually transmitted infections like bacterial vaginosis, candidiasis, which very rarely get transmitted to the man. Then you have the sexually transmitted infections now like gonorrhea, chlamydia, trichomoniasis. And so depending on what infection it is, then the person will have a different symptomatology that can be able to lead someone to know what kind of infection they're suffering from, and then they get treatment. And one of the best ways to prevent this kind of sexually transmitted infections, because what you're referring to tends to be an STD, is abstinence, maintaining a single partner, and of course, gloving up whenever or using a condom, that's what I mean, whenever you're having any sexual encounter. I hope that helps.
Thank you. Thank you so much, Doc. And thank you so much, everyone, even for coming in large numbers. And now I give this chance to Mr. David Musyoki, the CEO of Kehpca, to tell us something and also to close the meeting for us. Thank you very much once again.
Wow, what a moment, what a webinar, what a training, what a learning opportunity. Thank you very much, Dr. Mburu, for sharing great knowledge. I believe we can make a great clap and share our great emotions just to express ourselves. Thank you very much. Gladys, you've also been a great moderator. Professor, in moderating, we treasure your knowledge. Thank you for taking us nicely. The team behind the organization and coordination at Kehpca. You guys are great. I'm so proud of you. Everybody that attended and participated, you're our champions in many ways. We truly appreciate you. This could not have been successful if you were not here. Mary, your concern around the costs, yes, it's a concern of everyone, and Kehpca being an advocacy organization, it's advocacy that we need to build together. And so we need to continue talking about it in every forum, even as we structure, our conversation around support for, fertility preservation and all that. So we keep doing this. We are not in it alone, but we are in it all together. And I believe in the statement that together everyone achieves more. And we continue to do this as a team. So we look forward to greater opportunities in the future and better outcomes, even as we continue to structure this kind of talks. So we plan to give a short hold to the webinars because December is a celebration month. We don't want to have another webinar in December, but we'll pick it up from here in January. Thank you for your continued support. And if you have any other probably topics that you would wish covered, we have wealth of resource persons who are willing to be hosted, and we will be happy to get them wherever they are. Dr. Guru, you can be sure we will have you again for another topic or a continuation of the same based on the feedback that we receive. Otherwise, we bring it to close at that point, and I wish you all the best as we continue to advocate and be, the talk points about this important topic. We are all products of sexual activity, and so I believe it's that important. And so it needs to be part and parcel of our everyday communication, and more specifically, based on patients' families' needs, even as we attend to them. God bless you and all the best. Good night. We close the meeting at that. Bye-bye.
Thank you. Thank you. Bye-bye. Thank you very much.
Thank you.